Let us proceed. Let's proceed to the last talk of this session, which is the translation of anti-inflammatory nanomedical treatment for atherosclerosis into patients' first experience, presented by Professor Erik Stroes from Amsterdam.
After such a steamed talk, it gives me an extreme pleasure to yet introduce another indication to you, non-oncology. So after oncology, which were wonderful data, now you saw some pain data, and I will give you some atherosclerosis data, which I hope you find tantalizing also. So let's return very briefly to atherosclerosis. We've learned in atherosclerosis there are two major factors which initiate the disease. It's the yellow dots here, that's the cholesterol triggering the endothelium to give an endothelial adhesion molecule expression. Then it's pro-inflammatory monocytes entering the plaque. And as soon as the pro-inflammatory monocytes and lipids accumulate within the subendothelial space, you will see slowly the buildup of a self-perpetuating process. And if you're unable to hold this, eventually you run into the risk of the activated macrophages destabilizing the plaque, which gives you the event. Now the problem is you want to seize the process at least here, or maybe reverse, but at least you want to prevent the event. Now how should we do that? Well, we can either target lipids or we can target inflammation. Well, we've learned that lipid lowering is very effective, and we're very proud that statins and all the other stuff brings a lot of good things, but unfortunately it only prevents 25% of the events. So rendering 75% of the events completely unaddressed. So let's take the other approach. Will it be feasible to actually choose something in the inflammatory cascade which is involved in the process of atherosclerosis? Well, one of the easy targets would be actually the macrophage. Well, macrophages get activated, they secrete the metalloproteinases, and this is a key finding in destabilizing the fibrous cap and inducing the cardiovascular event. So can we target macrophages actually in atherosclerotic plaques? Well, we heard already about cancer, about the APR effect. Well, good for us that the hypoxia is largely present in the majority of all atherosclerotic plaques. We learned that the vasa vasorum are immature and there is much leakiness in these vasa vasorum. So actually, via various mechanisms, there is the possibility to target macrophages. Then if we target macrophages in atherosclerosis, we don't operate. Can we visualize whether we were successful in targeting? Well, good for us that, again, oncology, so it's good that I learned a lot about oncology today. Oncology showed that the PET-CT scanning is outstanding to show metabolic activity in cancer, but also in other highly metabolically active cells. So you give the labeled format of glucose, which accumulates within the cell and goes in metabolic trapping. Now, also in atherosclerosis, there's a large abundant evidence that the degree of macrophage staining in the plaques shows a very nice correlation with the FDG uptake on the PET-CT scan. So we could use indeed FDG scanning as a readout for macrophage activity in the plaques. And a very recent example of this was an elegant study by Marnan et al., who showed that patients having a cerebrovascular infarction in their head, if you make PET-CT scans, and you can see here the inflamed metabolic activity in the ipsilateral carotid artery, that the subjects with the highest uptake of FDG actually had a profoundly increased recurrent risk within the next year. So PET-CT activity is not only a marker for macrophage activity, it also indicates you're at an increased risk of recurrent events. Now, how can we translate this into the field of atherosclerosis? We collaborated with Gerd Storm and Mount Sinai Hospital in New York, and we actually addressed whether we could start an atherosclerotic trial to see whether we could answer whether inhibiting inflammation directly at the level of the vessel wall would be able to give us some advantage. Now, I will not go into the synthesis with all these highly esteemed knowledgeables here about how it was synthesized. I can only say that we used the method published by Bart Metzler and Gerd Storm, where they used the already discussed PEGylated liposomes with known patch density and patch length for optimal profiling. And you can see here that it was actually the prednisolone phosphate which was included in the nanocort. Now, first of all, the multiple dose studies in rats, where you show here a dose-dependent increase in the area under the curve, a very acceptable half-life of approximately 40 hours as opposed to the free concentration. And when you do repetitive administration, there were no signs of accumulation. So far, so good in the pre-screen toxicity trial. Now, what have we learned about atherosclerosis and actually being able to reach the vessel wall? If we put a little bit of gadolinium in these vesicles, you can see that using the double balloon injury high-fat diet atherosclerotic model in rabbits, you can see that these liposomes elegantly reach the atherosclerotic vessel wall. And you can also see that if you administer only a single dose of nanocort to these rabbits, within 2 and 7 days, you can reach a reduction using either 1 milligram per kilogram or 10 milligram per kilogram. And here PET-CT was used in this rabbit model. So in the rabbit model, we are highly successful in decreasing the inflammatory activity in macrophages and atherosclerosis. But how does this translate into humans? Now, we know that there's a big issue how we can translate animal data to humans. And in fact, if we look into detail, it's pretty obvious that if you look at the atheroma in animals where there is a micrometer dimension, and if you look what we actually see in advanced atherosclerosis in humans, there's a multi-millimeter dimension. So the way you can reach this as opposed to this may obviously differ. So the first thing we set out is to, after having evaluated PK of nanocort in humans, we actually wanted to know whether we were able to show delivery in the macrophages in the plaque of humans. To this end, we pre-selected patients scheduled for vascular surgery procedures, and we infused the liposomal glucocorticoid at day -10 and day -3. During the operation, we gathered the material and we evaluated the atherectomy specimen. Now, the atherectomy specimen was elegantly processed, giving us the isolated macrophages derived from the plaque tissue, surgically removed. And if we then perform co-staining on these macrophages, you can appreciate here the CD68 staining showing we did succeed in isolating macrophages. Here you can see the PEG staining, so the polyethylene glycol, which is obviously not present in humans. So this implies that these macrophages isolated from the atherosclerotic plaque did succeed in engulfing the PEGylated liposomes, and here you can see the co-staining. So the delivery of IV-infused PEGylated liposomes in macrophages succeeds. How about efficacy? Well, the efficacy was subsequently addressed using a similar design in patients where at day 1 baseline imaging was performed, then 2 repetitive infusions of the liposomal glucocorticoid, and between day 9 and 12 PET-CT imaging was repeated. What did we observe? Well, we pre-selected patients with a high target to background ratio, so we had inflamed atherosclerotic lesions. We included 30 patients at a 2-to-1 randomization ratio of active compound versus placebo. Here you can see the design. The safety in patients, after these 2 single administrations, we didn't see any significant safety signal, and I won't go into the detail because of time. Here you can see a typical example of the PET-CT scan. Here you can see that on CT there's calcification in this patient, which makes sense. We chose high-risk patients with cardiovascular disease, including calcifications. Here you can see the PET signal where there's an increased uptake, and if you overproject, you can see that the atherosclerotic tissue here shows increased PET-CT uptake, which we know from publications that in advanced lesions there is indeed high macrophage content. So what happened? We know it's delivered, we know there's inflammation. Well, this is not the final analysis yet, but the data we have to date actually shows that if anything we saw an increase. So how can we explain this? If we quantify it, we can see the placebo, there was no change, and the targeted background seems to increase to some extent in the actively treated patients. And here you can see the individual curves. Well, since this was unexpected, we also looked at dynamic contrast enhanced MRI, which is another way of evaluating inflammation of the atherosclerotic lesions. And here you can see again, you already saw this in previous talks, this high color indicates leaky vessels, so a lot of vasa vasorum, indicative also inflammation. And here there seems to be also an increase in the DCE MRI signal, so completely compatible with PET-CT, giving two independent imaging modalities, showing that you don't see silencing of your inflammatory activity. And here you can see the quantification giving a significantly increase. So what's happening here? We already heard Gert Storm telling us that in rheumatoid arthritis, you're very successful inhibiting the inflammation in the joints. And now we go to the atherosclerotic lesion where macrophages are, and apparently we don't see the same attenuation. So the only marked difference here is that we have a lot of fat tissue. So what we think, and we're currently working on the mechanism, that in this case we might run into the fact that we don't have macrophages, but we have lipid-loaded macrophages. And in fact, this may be an alternative way which we still need to resolve how we address this. So in conclusion, localized anti-inflammatory strategies are urgently needed to further reduce cardiovascular disease burden. Statins alone is not enough. PEGylated liposomes can be delivered successfully into plaque macrophages in patients with advanced atherosclerotic plaques. The plaque micromilieu may in fact affect the response towards the anti-inflammatory interventions. And so more studies are needed to identify better candidates for treatment in patients with advanced atherosclerotic disease. And I'm very happy that this is in fact will be evaluated in the ongoing Nano-Athero program supported by FP7 with Didier Le Tourneur as a central program coordinator. And with that I would like to acknowledge people from my lab, the PhDs, Fleur van der Valk, Diederik van Wijk, and Celides, Bart Metzelaar, Gert Storm, who is in the back of the hall, Mount Sinai collaborators Willem Mulder and Zahi Fayyad's lab, and then the financial support by the NanoNext with Gert Storm as the PI and the Nano-Athero with DJ Le Tourneur as the PI. Thank you for your attention.
Thank you very much for the presentation. It really seems that atherosclerosis is a little bit more complex than we thought in the past, and this also shows up in this trial. And these data, even if the outcomes are negative, they teach us more about the behavior of the plaque. So I believe we have gained from this study in understanding, even if you have not gained therapy which now cures all patients.
I fully agree. I think this is, if I'm very honest, this is one of the first times I'm happy with a negative trial, because in the ongoing studies, if you evaluate further, it shows us that the way we are currently treating inflammation in atherosclerosis as just another chronic inflammatory disease is wrong. And we know this because there's all the M1, M2 proliferation of macrophages, but also the oxidized lipid proliferation of macrophages. So I think what this will teach us is to more diligently look into the exact mechanism of the inflammation within the lesion, and will allow us to identify more feasible targets.
A very nice talk. I'd like to ask you how you succeed the targeting of the liposome in the macrophages, because I understand are your liposomes functionalized in order to have a specific target of the macrophages, because you have atherosclerotic disease in a human body, but you can have other areas of inflammation. So how you succeed in order to go into the atherosclerotic plaques?
This is just an indirect derivative of what has been presented by other much more knowledgeable people on the terrain in oncology. So we just use the EPR effect in atherosclerotic lesions. Since we have advanced atherosclerotic lesions with a lot of hypoxia and a lot of vasa vasorum, as attested by the DCE MRI signal also. So you have a non-specific leakage of the liposomes. We don't know yet how much the percentage of leaked liposomes into the atheroma as opposed to other tissues. So this is not selective to macrophages in atherosclerotic lesions. It's just apart from other sites, you also see accumulation in the atherosclerotic lesion. But this is not actively targeted, it's a passive targeting, yes.
have the problem, for example, if a patient has at the same time an inflammation, this other inflammation disease, or has a cancer and also has atherosclerosis, and if you use the EPR effect, so how the liposomes will go, fortunately, in other places. So
they go everywhere, that's very true, but take for instance now Novartis, who just invested in the canakinumab study where they give systemic IL-1 inhibition. So there's a lot of very non-specific studies using massive anti-inflammatory compounds, using the MTX study which is ongoing in the US, where they give methotrexate weekly to cardiovascular high-risk patients. So we all acknowledge the need to give anti-inflammatory compounds. I think the fact that we selectively target macrophages will give it the advantage that we expect that this is, since you only want to obviate the profound inflammation for a certain period of time, and if you succeeded in that, we expect you can stop and you can continue with oral medication like intensive lipid lowering or delipidating the plaque. So since we only aim for a selected period in time, I think for these very high risk patients who are at risk of just dying or getting a myocardial infarction, we may find a therapeutic window to actually use a stabilizing period followed up by a chronic, more safe period. And I like to compare it as the oncology version in cardiovascular disease. In cardiovascular disease, you have a myocardial infarction, you give a statin and say, go home. The problem is we might actually say, you are at very high risk now, we're going to do induction chemotherapy and then followed up by stabilization therapy. But this has to be worked out and there's a lot of things, details need to be filled in.
I agree with your assessment that good negative studies are, in a way, more educative than positive study, because you take the positive for granted and that's it. But the negative you have to study. I think your study raises a very, very critical issue. I mean, we're dealing here with few entities. You have the carrier, your liposomes. You have the specific aspect of the disease, and then the third thing, you have the drug. You're using steroid. Steroid is probably one of the best drugs on earth, but also one of the best toxins on earth, combined. It's even better than aspirin in many aspects, yes. I think.
And more toxic.
And on one hand, you cannot live without it as a drug. On the other hand, many times you want to keep away from it. Patrick, I'm right? Okay, so I think in your case, the major question is it related to the effect of the drug itself, per se, if you give it a controlled study with very large doses to kind of try to imitate what you get in the case of the drug, of the carrier, or it's related to the targeting to the site and so on? I think that's a very critical issue to all the field. Okay, because if steroid will be the one that's responsible for some of this effect that you see, it's completely another matter.
Let me give you two arguments. The first argument is that if you go back to literature, that all the literature used steroids in cardiovascular disease, you always see a profound increase in cardiovascular events. Sure. Now that has always been attributed to diabetes, hypertension, etc. But if you do statistical correction for all these additional risk factors, you still have an increased risk.
So you have the answer.
So that's the first. And then the second, so we thought it could be the prednisone. So if you go back in literature, and we're currently finalizing the data in mice because it's much easier to get tissue in mice. If you go back in literature, there's some very interesting data there. Because if you give prednisone to inflammatory macrophages, you completely silence them. Easy. If you give prednisone to macrophages who have engulfed a lot of oxidized LDL, you see a completely different pattern. So that implies that most likely there's a direct alternative effect of prednisone on lipid-loaded macrophages, okay, which may contribute to what we see here. But unfortunately, I can't give you the data yet. We expect those data in a month.
It shouldn't be too difficult to do.
No, I agree. And we'll have the answers within a month.
Should be very, not very. I think it's very critical to all the field, not only to your
I
study.
totally agree. And then comes the issue that we have to go back into the consortium, because then we have to find a better agent. Now that we did show successful delivery, what agent are we going to deliver then?
Let's now select what is the best anti-inflammatory to use that will not have this kind of effect. But this you will have already a tool to evaluate, because if you find you take a macrophages from patient that you can work with for a little time, and then you can get answers, then you have a good screening way.
Absolutely. I fully agree.
Okay,
Thank
good
you.
luck. I'm waiting to the results.
There is another question. There was another question. Do you want to...
My question was related to the PEGylation of your particles, because you are targeting macrophages, and as far as I know, hydrophobic nanoparticles can be uptaken better by macrophages. Why do you use PEGylation for the liposomes?
Well, I've learned that you should never acknowledge or give answers to a field where you actually lack knowledge. So, Gert, maybe you have a microphone. Can you give this answer?
Or Gezi, or many others here.
Yeah, but you gave me the liposome,
Oh,
so
yeah,
you can
yeah,
answer it.
I forgot about that. No, but it's also, PEGylation is a way to prevent macrophages and to oppose uptake by macrophages, particularly the Kupffer cells, and you get a longer circulation time. But as soon PEGylated particles arrive in a pathological area, it's a matter of time. Also, the ultimate fate of these particles are the macrophages, can be the macrophages, and in particularly in inflamed joints of rheumatoid arthritis patients. These macrophages are also highly inflammatory. They pick up these liposomes. So it's not a block, it's just opposing, but ultimately fate of the majority also of PEGylated nanoparticles is the MPS system, mononuclear phagocyte.
I think this, what Gert said is 100% correct. I think you can, with PEGylated liposome, completely eliminate uptake by macrophages. For this, you need to add 10 mol% PEG DSPE, for example, or less of PEG 5000, and then you block completely. But this liposome will circulate for such a long time, you cannot give a second treatment. So, I mean, the reason that we at the Doxil selected what we selected was not just a random. It was a choice of some work with macrophages. I think I show a slide, I didn't talk about it, but basically it was done exactly for what Gert said, that at the end there will be macrophage clearance, because otherwise you got stuck with this lipid and you don't want to have it, really. I think it's very dangerous. It's not very good.
Okay, thank you. Now, on the program there is still a discussion after the discussions of the talks, but we have discussed a lot, so I would like to ask you, is there any important question left for any of the speakers of the whole session? If not, let's conclude this session and go to lunch.